Good morning and welcome to Monday Mornings with Margie. I feel very fortunate today to have Peggy Huppert with me. I'm going to let Peggy introduce herself and then we'll move on with our topic.
Well, thanks for having me. I really appreciate it. Marjorie, my name is Peggy Huppert, and I'm the Executive Director of NAMI Iowa. That's the National Alliance on Mental Illness. Probably a lot of your listeners know that we have organizations across the country. We're the largest and oldest grassroots organization working on issues around mental health. Here in Iowa, we have 13 local affiliates. And we work with thousands of people across the state every year on providing resources, education, support, and advocacy around mental illness.
Oh, great. Well, we're really happy to have you. And, you know, one of the things I was thinking about in, talking more about Iowa and the Midwest, and some of the areas you're working in communities that you're in, is what are some of the challenges that you find that are impacting rural communities around mental health and/or substance abuse?
Well, there are some unique challenges. They're not unique to Iowa, but there are some unique challenges to all rural communities. And one is the lack of providers. Iowa, unfortunately, ranks very low in a lot of different areas related to mental health. And some of those are providers, starting with psychiatrists. We are always in the bottom 5 for the nation in number of psychiatrists. We have fewer than about 120 psychiatrists serving the entire state.
Wow.
So about 600,000 Iowans have a mental health condition, and we have about 120 psychiatrists, only about 30 of whom are child psychiatrists, so even fewer of those. Mm-hmm. But we have a shortage of providers across the board. We really don't have enough of anyone at any level. But it's not uncommon in more rural areas of the state for someone to have to travel 2 hours to see a provider, mm-hmm. and to have a wait time of 3 to 4 months to get in. So that's a problem, because especially if you're in crisis, and unfortunately, a lot of times people wait until there is a crisis before they reach out for help.
Sure.
And unfortunately, often no immediate help is available.
Right. So
it's a real problem that we have faced for a while now. Mm-hmm. There are lack of enough beds and the right kind of beds to help the people who need it, especially anyone with any kind of complex condition. Mm-hmm. We don't have the right provider mix. We don't have enough community-based services. Mm-hmm. So for people who could successfully live on their own, if they had the right kinds of supports and services, we don't have enough of those either. Mm-hmm. So we have a lot of needs, and again, it's not unique to Iowa, unfortunately.
Sure.
So there's also we find more of a prevalence of stigma, which I know is one of the questions that you had raised. There is no doubt that in rural communities and small towns, there is often more stigma attached to seeking help for a mental health or addiction issue. Mm-hmm. Which people have told me, I don't want my car to be in that parking lot.
Yeah.
Because people will see my car in the parking lot.
Right.
And therapists have told me that, they won't say hi to clients in the grocery store, because they don't, people don't want anyone to know that they have it. Now, it's unfortunate because mental illness is an illness, just like any other illness. And one would not be ashamed to have their car seen in the cancer clinic.
Absolutely.
Or the ortho clinic, right? Or the heart clinic.
Absolutely.
So it's really sad to me that is still the case, but it is.
Yeah, the last discussion I had was centered around stigma, just stigma in general around mental health. My dogs decided to join us. This is Gronk, everybody. You've seen Gronk before. Yeah, and I was wondering, specifically in rural communities where people know each other maybe more intimately, and how that works. I was wondering, how do psychiatric nurse practitioners help, and how does telehealth help in rural communities?
Well, that's a great question. And what we know is, I say this often, we're never going to have enough psychiatrists. And really, psychiatrists are often really just med management. You see them for 15 or 20 minutes every 3 to 4 months. That's it. So there's a lot of other stuff that really should be part of an effective treatment program or plan, besides and in addition to a psychiatrist.
Absolutely.
But a nurse practitioner can prescribe. There is a psychiatric certification available for both nurse practitioners and physician assistants. They're both prescribers. So in rural areas, they could well be the person you see. And that psychiatric certification really means that they are very up to date often on the latest medicine and all that, the latest research. So they play a very important role, and we'd really like to see more of them. That could really fill a need. And honestly, in many rural clinics, that's who you are seeing. So that's important. Telehealth has been a true silver lining of the pandemic. We know that it has been used extensively, especially in the behavioral health field. And the changes in rules and regulations and reimbursements, I call it it's the 3 R's, have made all the difference, because people can now access it. Before, there were so many requirements for related to privacy and encryption that it was virtually impossible for anyone to do from their own home. So they would have to go into a hospital or a clinic to access telehealth, which is kind of ridiculous. And especially in a pandemic, you would want someone to be able to access it from their home. So they relaxed those rules. So now you can do it over a Zoom or FaceTime or other platforms. They've made it so that you can do it with audio only. You don't have to have the visual piece of it, which is important in a state like Iowa because we don't have the best broadband access. So people can't always access the visual component of it. So more and more is being done via telehealth, and we really want to see those changes be made permanent, because we think it will help a lot with this access issue. If someone in the far northeast or southwest corners of our state can access a provider in a metro area rather than having to drive for 2 or 3 hours.
Absolutely. Absolutely. We've seen it out here, even in Massachusetts and Connecticut, just the need and the thorough usage of it out here. And I suspect from what we're seeing that there will be some permanency, at least for some health insurances. You know, it would be nice to see if something like CMS and Medicare in particular, and the Medicaids in particular would really think about this as a permanent fix that would also potentially help, in my mind, with no-show rates for people as well.
It is. The data shows it is helping with no-show rates, which makes sense, right?
Right.
Because you can do it from your own home. Whatever barriers you can reduce, that is going to, at least theoretically, help with no-show rates, which, especially with the Medicaid population, has been traditionally a real problem. Yep. So, you know, actually, in this case, government is leading the way. Medicare has already said that these changes will continue through at least next year. The Trump administration has proposed that they be made permanent. CMS seems to have really turned around on this. I think I said, you know, sometimes it takes a crisis to and make advances. We've been working on this for a while, and you know, 3 or 4 months of practical experience have made all the difference to show why it can be very useful. So I think Medicare, we will see it continue. I think in Iowa, at least, Medicaid is also very open to continuing it. We're a managed care state, and the managed care organizations seem very open and fine with that. Our problem is with our Wellmark. Blue Cross Blue Shield is our primary private carrier for health insurance here. They have about 80% of the market, and they are not keen on it. So we're going to, as advocates, we're going to have to, I think, fight for the reimbursement, the parity to continue, because they seem a little hung up on, we don't want to have to pay the same for a telehealth visit as we are for an in-person visit, even though what we know is a lot of those costs are still there. And so it's something we are certainly going to be working on and continuing to advocate for.
Sure. And when you think about that sort of way of thinking as well, if you don't want to pay the same rate for telehealth, therefore you have less providers, say, you're going to pay in the end, because if the person doesn't get the help they need and they end up needing a higher level of care, then you're going to pay for the higher level of care, and the person's in crisis. And worst case scenario, the person could end their own life.
Right.
And so, you know, it seems to me like you're right. I think COVID has, you know, showed a lot of different things that aren't working in our country and could work if we made these changes. And so I do think that is one of the silver linings, I guess, of this whole situation we're in, to try to make sort of permanent change in healthcare, but in particular in mental health.
Yeah, we really agree with that. And it's a priority for us nationally at NAMI. We're working, I know, with a lot of provider groups on this, because our interests align in making sure that people get the help they need when they need it. Right. And it's certainly true that the ultimate price is if someone takes their own life. But we know that if people do not have access to care because of the behaviors that are often connected and attached to mental illness, that instead they could end up in the hospital emergency room, in inpatient care, which is very expensive, and not everyone needs that level of care. It's just where they end up. Because of there's not a lot of options. Or the other place they tend to end up is in jail, or ultimately in prison, but jail initially. because they get in a tangle with law enforcement. So, and once you're in the justice system, it is really hard to extricate yourself. So that's a whole nother level of, we talk about wanting to divert people from law enforcement, from being involved with law enforcement or from being jailed, but you have to have some place to divert them to.
Sure.
So the first step would be when someone first reaches out and someone wants help, that we make sure they get the right help as quickly as possible.
Absolutely. Absolutely. So one of the things I was thinking about, not being from the Midwest, I have some family that have moved to the Midwest and know people from the Midwest. A lot of what people talk about are Midwestern values. And I was wondering, being a, Northeastern person of the country, how do you see Midwestern values play out as far as how mental health is viewed, substance abuse is viewed, either in a good way or a bad way? Or is there no link? I'm just curious.
Well, I'm sure that, and I'm a lifelong Midwesterner. I actually grew up in Wisconsin, okay, and then have lived in Iowa since college. And a Midwestern value is personal responsibility and autonomy. Mm-hmm. And we see that play out in different ways. But one of the negative ways it plays out is in a belief that I can handle this myself, mm-hmm, right? I don't need help. Mm-hmm. And that is very rarely the case, mm-hmm, when it comes to behavioral health needs, whether it's mental health or addiction. Sure. Most of the time, you do need help. Mm-hmm. Okay. But also there's both in the South and Midwest tends to be higher levels of involvement with organized religion. Mm-hmm. And sometimes the ramification of that is a belief that my mental illness or my substance use disorder is rooted in a lack of faith. Mm. It's a personal failing on my part. Mm. I don't have enough faith. I have a defective character. It was something to do with parenting, bad parenting. It's somehow somebody's fault, and blame has to be assigned. Sure. And that still runs very strong. I hear that still a lot. Wow. And obviously, that's a huge barrier to reaching out for help and getting the help you need. If you're suffering from a lot of guilt, or if you're a parent and you're seeing problems with your child, mm-hmm, you don't want to ask for help, because if you think it's your fault somehow, sure, then that's a really heavy burden. So that would be, I would say, a barrier. Now, on the plus side, Midwesterners usually are honestly pretty honest, open people. Mm-hmm. In that sense, they are sometimes, especially, and I'll say there's a difference between males and females. Mm-hmm. Mm-hmm. I kind of joke that older white females are, like myself, are usually very willing to ask for help and be open about their problems and issues. I will also say I have 3 millennial children, and I think the younger generation is doing much better, sure, at talking about their issues and asking for help. But there are exceptions. There was a big report the CDC came out with a couple of years ago on suicide. They called it a public health epidemic. Mm-hmm. And what we know is that often when young men from cultural and ethnic minorities, racial minorities, take their own lives, that their family and friends are much more likely to say that they had no idea that that person was suffering, because it was never disclosed. Because there are still some very strong stigma attached in certain groups of minority, ethnic, and racial populations. Also, men tend to be less open and more resistant to asking for help.
How do you see it play out in the Midwest as far as the LGBTQ plus community?
That's a great question. And we've done a lot of work with that community in outreach, and because there are certain groups where there are higher levels of mental health and addiction challenges, and that is one. Which makes a lot of sense because that population is under stress. They're already facing stigma just about who they are, especially young people.
Sure.
And so it's probably not too surprising that anxiety and depression will be outcomes of that. And then, substance use is often a coping mechanism for dealing with an underlying mental health condition.
Right.
So, nicotine is a very effective anti-anxiety drug, right? Which is why people use it. Alcohol is something that people with chronic depression often use. Now, it is a depressant itself, so chemically speaking, that's makes absolutely no sense, but it's a way of coping.
Sure.
It's a coping mechanism. Meth is a highly effective anti-anxiety drug. So there are reasons people use and then end up, unfortunately, abusing substances. Often, in about 75% of the cases, is because of an underlying, usually undiagnosed mental health condition.
Absolutely. And trauma also is
absolutely
one of the things that's at the core of that as well.
And that's also something that is disproportionately present in the LGBTQ community.
Yeah.
Is trauma.
Absolutely.
So, yeah.
So, in sort of just wrapping up our discussion, I'm just wondering, what are resources that either NAMI provides or other resources that you have found that are helpful for people who are struggling, whether it be in a rural community or not? What have you seen that's been most helpful for people?
Well, the beauty of NAMI is that we are all people with lived experience, whether that is as a loved one, a family member, or a person who with a mental health condition ourselves, who are trained to help others. So that's what NAMI is all about. And we have education classes to learn more about the illness. Those are we have classes specifically for parents of younger kids. We have classes for loved ones of active duty military and veterans called Homefront. We have support groups for both people with a condition and with loved ones. And we have presentations that are we do to both with clinicians and with community and faith groups to help people understand and learn more, because the more we all talk about our own experiences and make it acceptable to do so, the more people are going to be willing to do that themselves and to ask for help. So that's what NAMI is based on. And I always say, going back to we're never going to have enough psychiatrists, right? psychiatrists are really just one small piece of the overall puzzle of what is needed for many people. And NAMI, with our community supports, is really what that's called, is we're kind of just there always to provide help and hope. So I would always encourage anyone to start their search by going to the NAMI national website, or every state has a state NAMI chapter, and then most metro areas have their own local NAMI affiliate. There's often these classes and support groups are being offered. And many people say, I had no idea, because unfortunately, often they're not referred, they're not told about it. So I would encourage people to start there. And then, like in Iowa and in many other places, we offer a resource and referral. So Monday through Friday, 9 to 5, people can call our office with any kind of problem or issue or challenge around mental health, and we will help them.
That's great.
So
that's great.
Yeah.
Well, I appreciate your time, and I appreciate, even though, hearing some of what you've shared, can feel a little defeating at times. I think we're doing what needs to happen. We're continuing to talk about, mental health issues, about different communities that are impacted about it, and just like stopping the silence is what is really important to me, both with Achieve, but I was a therapist for 18 years before I took on this role, and worked with many people from little to older. And it can be a really lonesome and painful experience, and not talking about it is the worst thing that could happen. And so my goal is to talk about as much as we can, and to let people know, what the resources are out there that they can access, or the call they can make that can help them get where they need to get. So.
Well, one of the things that NAMI does really well that I'm very proud of is advocacy. We are involved at the state level very heavily, and also at the national level, advocating for better laws, better policies, better programs to help people. And that I have found is a very effective way for many people to feel like they're, once they're in recovery, to be able to give back and to feel like they're making a difference. Is to get involved with changing public policy and educating policymakers about that. So like in Iowa, we have a unique opportunity with the caucuses. And last year we had a whole core of people who were out there talking with the candidates and their staff people, and which resulted in a lot of the candidates coming out with major policies around mental health. So that's a concrete example of how people can be involved to make a difference, not just in their family or their immediate circle, but beyond that.
Sure.
And I think that's a really neat way for people to get involved, like I said, beyond just their circle. But we do have a program called Ending the Silence, actually.
Okay.
And it is designed for middle and high school kids. It's done by a parent, an adult, and then a young adult. A presentation of 50 minutes, and the whole idea is to, and there's also a version for educators and a version for family members. So it's a great community resource for people just to learn about the basics, and for a young person to understand if I or someone I know is experiencing these symptoms or these challenges, what do I do? Who do I turn to? How do I get help? And that's what we're trying to do.
That's great. That's great. Well, I appreciate your time today. And I want to just say thank you to the people who took time to listen or watch this podcast and YouTube video. And I hope you have a great week, and I will see you next Monday. Thank you.